Hello, everybody. My name's John Wilding. I'm currently president of the World Obesity Federation, and it's a great pleasure to welcome you all to this reflection on COVID-19 obesity that we've called Joining the Dots. We can have the next slide, please. So just a reminder to everybody that this meeting will be recorded, and you can use the Q&A function to post comments and questions. We will give everybody the opportunity to ask questions after each speaker, although there is fairly limited time for this. The recording, the slides, the feedback form, and a certificate of your attendance will be circulated after the webinar. Next slide. This is me. I think I've already introduced myself, but I'm based at the University of Liverpool and Aintree University Hospital at Liverpool in the UK. And as I've already said, I'm currently leading the World Obesity Federation as its president. So our agenda today, I'm going to give you a very brief update on COVID-19 and obesity, but I think the real detail will come from our 5 speakers who are going to reflect on different aspects of COVID-19 and obesity. Tasha Mayakakora will talk from the perspective as a youth board co-chair of the Bite Back meeting, which looks at food systems. We're going to hear from Dr. Ada Kivas, who's based at the Catholic University in Chile from a clinical perspective. Tallulah Oni is part of our public health guidance, and she's going to talk about public health aspects, and we'll hear more about that from Fatima Cody-Stanford from Harvard University and from Karina Hawkes from City University London. We then have a little bit of time where we will take more questions and have the opportunity to discuss any questions that are raised by yourselves in the Q&A panel. And then finally, we have a little bit of time to sum up and look towards the future. So here's our panel. I've already introduced them briefly, but as you see, we have an international panel. Although 3 of them are from the UK, we have tried to make this as international as possible. And the first person that I will introduce will be Tasha in shortly, but first I'm going to go through my own slides. So it's been a difficult year, I think, for everybody. So we've all, I think, in various ways, COVID-19 has impacted our work, and certainly it's impacted the work of World Obesity. As a result of some of the research that really came out very early, indicating that obesity was both a risk factor for and certainly for severity of COVID-19, we developed a scope module around obesity and COVID-19, and have also run a number of these webinars, which I'm sure many of you have participated in. We've also focused on other areas such as the impact that this might have on our work in childhood obesity, and provided weekly updates. We also have collected some of the key papers and information about COVID-19 and obesity, and put this together into a dossier that is available on the World Obesity website, and we have really quite extensive resource there if you're interested. Next slide, please. I think everybody knows that this epidemic is spreading worldwide very rapidly. And we're now, this is the Johns Hopkins dashboard, but you can see here that we're now at a point where there are over 65 million cases globally, with sadly more than 1.5 million deaths. And these are really spread around the world, with significant numbers in countries like the United States, but also in other parts of the world, such as Brazil, India, Mexico, Europe, including the UK, where I am based. And of course, the reason why we're particularly interested in this epidemic, World Obesity, is because of this evidence that emerged very early on, but is now really very clear, that it appears that obesity is both a risk factor for acquiring COVID-19 infection, and you can see the data here from a large study in the UK, as well as many of the complications of obesity, also independently increasing the risk of developing COVID-19. And then if you're unfortunate enough to catch the virus, your risks of being hospitalized, ending up requiring intensive care, are also very clearly related to body mass index, as you can see here, and particularly those people with a body mass index over 35 with more than 4-fold increased risk of ITU admission. And again, this is exacerbated by many of the complications of obesity that may also be present in the same individuals. Next slide. The mechanisms of this have been a focus of a lot of scientific attention, and I think they're really beautifully summarized in this paper published earlier this year from Professor Naveed Sattar in Glasgow, which highlighted, firstly, how people with obesity are perhaps more likely to come from groups with lower socioeconomic status, maybe have a poorer diet, maybe less physically active, and maybe coming from some ethnic groups. That presence of obesity and excess ectopic fat will have adverse effects in many ways that mean that the infection is likely to be worse. Certainly there are mechanical problems, reduction in lung capacity, and also mechanical problems affecting the heart, as well as metabolic problems affecting the heart that lead to lower cardio, respiratory and metabolic reserve. And ultimately, also that seems to be linked to an impairment of the immune response. And then we also have a dysfunctional immune response, which may be directly related to adiposity. And all of these things mean that COVID-19 is more likely to be severe and more likely to lead to intensive care treatment and higher mortality, therefore, in people living with obesity. Next slide, please. We also have to remember that it's not just a one-directional problem. There is also the response to the pandemic that also creates problems for people living with obesity. Lockdowns lead to a lot of isolation, may increase stigma. And of course, so many patients that I see are telling me that they're gaining weight because of comfort eating, restrictions on their physical activity. And we do see this COVID weight gain clinically. The economic effects are likely to make things worse, with food poverty, increasing use of processed foods and snacking, and also effects on the access to healthcare, not just for aspects of complications of obesity, but also for obesity itself and investigations and treatments. And overall, all of this is leading to an increased risk of comorbidities and multiplying the problems that already exist in many people who are living with obesity. Next slide, please. So we need to think how we can embed our thinking about obesity into the pandemic response. And we've highlighted 3 key areas here, and I think they're probably fairly obvious to all of us. But firstly, making sure that everybody has access to adequate and complete nutrition, but with clearly a focus on the most vulnerable people, and reducing, where we can, reliance on highly processed foods that are likely to contribute to the development of obesity. Physical activity is really important for all of our health, and we should encourage people to remain physically active even during lockdowns. Outdoors is obviously better than indoors, and where we can use alternative modes of transport to avoid, for example, transmission on public transport. Prevention and treatment are both really important, and it's vital that we make sure that the public health messaging is consistent and that we are able to still provide treatment support for those people that need it. So I'm going to stop there and hand on now to our next speaker. If I could have the next slide, please. And as I've already introduced her, Tasha Mayakakora is a youth board member from Bite Back UK, and she's going to give us a useful input, I'm sure. Over to you, Tasha.
Fantastic. Thank you so much for the introduction, John. Thank you so much to the World Obesity Organization for allowing me to take part in this really interesting series over the last couple of months. And just to see so many people working towards a common goal has been very encouraging for a food activist like myself. So yeah, like John said, I work for an organization called Bite Back, and we work to improve the health and well-being of young people by exposing the truth about how the food system is designed, but also looking at ways that we can redesign it to make sure that it puts young people's health at the forefront of its operations. So when I think about the impact of COVID-19 on children, one of the biggest issues that has risen out of the pandemic for me is that the food and drink manufacturers have turned the pandemic into the world's largest marketing campaign. They have used the pandemic to promote their product at the expense of public health. So the industry has been really productive in producing aggressive marketing strategies that heavily advertise unhealthy food options, food that are high in fat, salt, and sugar, to the most vulnerable members of society, that being children and young people. And they've also done a good job at tapping into feelings of nostalgia and togetherness and a sense of normalcy and security, all of which are the things that consumers are all looking for right now. Their response has only highlighted the manipulative nature of the food industry and how it puts health at the forefront of its operation and actually neglects the impact that it has or the role that it has to play within society. Moreover, through all of this, young people and children have been bombarded with adverts from food delivery services with the interest of influencing our food options. The majority of options on sale offered by the likes of Deliveroo and Just Eat are highly processed items, foods that we should try and limit our consumption of. And like I said, they've really played on young people and children's impressionable nature. Again, this all highlights how much work food activists like myself have to do. So I do take that as a silver lining in all the chaos that has been going on in the world at the moment. On top of that, I think the pandemic has led us to become more aware of the social inequalities within society, but it also has given us the opportunity to act and rebuild a more equal society. So it's exposed, different things, really important issues such as racial inequality, health disparities, and some of the weaknesses and cracks in our public services. And all of that wouldn't have been possible without the pandemic. A lot of the time we don't know how to act or how to improve our society until we realize, oh, it's faulty in this area. So I do think that, the silver lining in all, in COVID-19, in the pandemic, is that it's really given us the opportunity to really think about how do we reconstruct and build our society to better prioritize health, or to make sure that it's equal and fair for everybody that lives within it, and kind of address the different social disparities that we have within society. And finally, I think the role that young people have played in catalyzing action is that the pandemic has given young people a platform to really amplify our voices and express our concerns and worries and angers and frustration, all through the use of social media. For example, a campaign that was run by Christina, my co-chair at Bite Back. So she was campaigning on free school meals, and that received a lot of attention from influential figures like the likes of Marcus Rashford, who then as another young person, used this platform to extend the free school meal for all children during all school holidays, all the way up until April 2022. The original intention was just to cover, Easter and the summer holidays. But again, we can see how the collaborative effort of young people using our platforms, voicing our opinions, has all added to this momentum to try and change our society for the better. So whilst I do recognize that there are so many challenges that all of us have faced during COVID-19, there are some golden nuggets that we can take away from it. That is, looking at different ways that we can rebuild society, but also how young people have been able to use it as a moment to really amplify our voices. But other than that, thank you so much again to World Obesity for having me this afternoon, and I look forward to the discussion coming up.
Great. Thanks very much, Tasha. Hopefully my video will come back on now. Yep, there we go. So I'd now next like to introduce Dr. Ada Kivas, who's the Medical Director for the Center of Advanced Metabolic Medicine and Nutrition at the University of Santiago in Chile. And she's going to give us an oversight, I think, from the medical perspective. Over to you, Ada.
Hello to everybody. Well, after this pandemic, I think that we have to consider that people living.
You're muted, Ada.
Now it's okay.
Yeah.
It's okay now?
Yeah.
Yeah, okay. So as I was mentioned, after this pandemic, it's very important that people with obesity need to be truly considered to have a chronic disease that in addition to their increased risk of other chronic comorbidities, also increase the severity of acute disease such as COVID-19. So they need and deserve an early diagnosis and appropriate treatment. Therefore, it's important that the health system, either public and private system, can improve the plans and programs to improve their treatment. And regarding specifically to COVID-19, I think that we need to develop more research in order to know the mechanism that explain this higher risk. We know that we have better knowledge about this mechanism, but it's important to study more about this aspect. And finally, from the general point of view, I think that it's very important that the society respect to patients with living with obesity, and of course the healthcare professionals. In addition, another reflection is the change in our care with our patient, specifically with telemedicine. I have to recognize that 1 year ago I never used telemedicine. And this year, in a very fast track mode, I have to learn how to use it, and it was very, very important, mainly during quarantine, to maintain the medical control of my patients. I think that it will remain, certainly will remain in our clinical practice. It will not replace the face-to-face consultation, but will be complementary and will be very useful, mainly for people that have to travel long distance. It will reduce the missing appointment. It will improve the adherence, and of course will improve the results of their treatment. And another aspect that is very important to consider is the concern that our patients have after this pandemic. They have concern about the risk associated to their underlying disease. They are more worried about that because they are watching the TV about all the problems associated to obesity. So they have concerns about that. They have concerns to get sick by COVID-19 and have a severe disease, even lethal disease. They have concern about the effectiveness of the vaccine for them, that appear in the media. And of course, they have concern about the economic impact of the pandemic that obviously will affect their treatment. And they have concern also about the delay and even lack of medical attention because the overdemand that the health system is having and will have for the attention of many other pathologies that were not attended during the pandemic. So we have a big challenge in a short time and in the long term to improve the medical care of our patients with obesity.
Thanks very much, Ada. It's great to hear that you've managed to do so much to continue to support people living with obesity despite all the restrictions of the lockdowns and so on and so forth. And I'm sure we'll have some discussion about the advantages and disadvantages of telemedicine and other remote ways of supporting people living with obesity when we come to our panel discussion later on. I'm going to move on now to our next speaker, who's Dr. Tolu Oni, who is a senior research associate at the Global Health and Activity Research Group at the MRC Epidemiology Unit in the School of Clinical Medicine in Cambridge in the UK. And I know that Tolu's work has focused a lot about cities and how we can make cities more appropriate for active lifestyles and ensuring food systems are right. And she's particularly, I think, been interested and done a lot of her work in Africa. So this is very relevant, I think, to the discussion. So I'm really interested to hear what Tolu is going to have to say. Over to you, Tolu.
Thank you. Oh, I'm unable to start my video, but I'll just get going. Okay. Thanks for the kind introduction and for the invitation to reflect a little bit on where we are in terms of obesity and COVID. So I'll focus on inequity particularly from the context of prevention. Obviously, because we're talking about a disease that has significant where factors that influence its incidence and prevalence lie largely outside the healthcare sector. In particular, I want to reflect a little bit on the realization of what we're dealing with, what we've been dealing with here with COVID in general, which is inequalities and inequities in the context of complexity and uncertainty. And I think the scale of the pandemic has brought to the fore the reality that we can't shy away from addressing a disease or a syndemic without addressing that complexity and uncertainty. And I think that's something that we've generally shied away from, even though we're dealing with these complex issues. So as John mentioned, a lot of my focus is on cities and urban health, urban epidemiology, where we look at ways in which the urban environments, the natural and built environments can be harnessed and repurposed really to support healthy eating and active living. And part of the reason I'm particularly interested in cities in Africa is because that's where the cities are growing very rapidly. And so you have a dynamically changing environment, which poses a lot of challenges to health, but also the opportunity to actually intervene. So I think the two key things reflecting on this, I should also mention that in these contexts, the day-to-day has for a long time embraced and had as key parts of it uncertainty and complexity. So if you speak to somebody navigating Lagos or Accra or Nairobi, the day-to-day lived experience of transport, of getting to work, of eating, of socializing, already involves complexity and uncertainty. And yet somehow, often with research, we almost isolate and sanitize those environments just because they challenge our notions of what we measure. So really, I think the two key points I want to highlight in this context are one, the importance of intersections, and two, the notion of resilient interventions. So firstly, from the perspective of intersections, I think one of the things that has really hit home in the context of obesity and COVID is firstly, how addressing such a complex issue requires a cross-sectoral approach and coherence across these sectors. So you have spaces where, even in addressing the COVID pandemic, if the economy isn't speaking to health, isn't speaking to trade, and you don't have coherence, there's a clash and a missed opportunity really to protect health. What we've seen, some of the responses that we've seen in addressing COVID have highlighted what could be and what is possible. So I've spent a lot of time, for example, in the built environment and speaking and collaborating with urban planners and architects and people in the housing space. And the challenges are really often around mandates. And it's like, oh no, we don't do health and this is not what we do. And yet when we had this very clear and present danger and emergency, these are the very sectors that worked across silos to address transmission of COVID. And so this is something that we can learn in terms of what is possible. So if we're thinking about obesity and prevention of obesity, a lot of the work that we do is around looking at the influences of the food environment, influences of the built environment, how those are changing, and how those can be purposely designed for health. And so the critical thing now is having these different sectors continuing to see themselves as key role players in health. And so that's intersections. And then the second point I wanted to make was around resilience. And in this context, I don't want to focus on resilience of people, because I find resilience sometimes a bit of a problematic word, because it often implies or sometimes it's treated as a reaction to the inevitable, as opposed to reducing risk. So we've seen in the COVID inequalities and obesity, inequalities with respect to exposure to environments that are conducive for healthy eating and active living during the pandemic, in terms of vulnerability and the distribution of obesity across the population is not distributed equally, and the socioeconomic dimension there, and also in the access to care. And so when we talk about resilience, I want to ask the question, in what ways are we thinking about the interventions that we design to promote healthy eating and active living and reduce the prevalence of obesity? In what ways are those interventions, in what ways can we ensure those interventions are resilient to complexity and resilient to disruption? Because we also obviously faced with a climate emergency, and we know these disruptions are happening regularly. So how do we ensure, the previous speaker spoke about the opportunity that has been taken to market junk food to children as part of the pandemic response. And so how do we think about interventions, not just in peacetime, as it were, when things are normal? Because the reality is the abnormal is occurring quite frequently, and in places where we're seeing rising obesity, people in those cities are confronting chronic stressors that mean that often a lot of the interventions that might be proven clinically to work, and by clinically I mean in a sanitized research environment, are not actually sustainable, or are not actually resilient in the context of physical activity and floods and extreme heat, in the context of food, healthy food access in societal disruption and socio-political conflict. So how do we think about the resilience of our interventions, bearing in mind this complexity and uncertainties which are likely to increase? And I think the last point I wanted to make really was the importance of a rights-based approach. So we talk about the right to health, and that is often spoken about in the context of healthcare access, which is really critical. But a key part of those, the right to health there, is the right are the rights to the health determinants. So in that same document, the UN document also speaks to the rights to healthy housing and human settlements, the right to food, healthy food. And so it's really critical that we also take a rights-based approach to identify, well, where are we reaching and where are we failing to reach people? How do we measure what we're doing? So how do we measure changes in these environments over time? How do we measure what we value and not just value what we measure? Because the reality is these complex issues pose challenges in measurement, and we have to rise to those challenges from the scientific environment perspective. And lastly, the importance of context in taking that rights-based approach. So and I really like the first speakers talking about that participation and engagement with young people, and the importance of understanding that lived experience and integrating those lived experience and those experiences and those contexts into design of resilient and sustainable interventions to prevent obesity. So those are just some of the reflections that I've had over the last few months on this.
Great. Thanks very much, Tolu. That was really interesting. We will now move on back, I think, more towards the clinical arena, and I'm really pleased to introduce Dr. Fatima Cody Stanford, who, as I already said, is from the Massachusetts General Hospital, Harvard Medical School. She is a trained obesity medicine physician, has held a number of really important leadership roles, and is also, as you can see here, Director of Diversity, Nutrition Obesity Research Center at Harvard, and the Director of Anti-Racism Initiatives in the Neuroendocrine Unit at the Massachusetts General Hospital in the United States. So Fatima, over to you.
Okay, thank you so much for having me this morning. Of course, it's just a little bit earlier here in the United States, so if I seem a little tired, hopefully I'll bring through some effervescent energy as we go through this presentation that I presented, which really focuses more on the policy issues surrounding overweight and obesity. And first, I'll start with the context of looking at what we're seeing here in the United States. As we know, obesity and COVID appear to be very pronounced here in the United States compared to other countries. And so I want to speak on that and then go into what we're looking at from the world perspective of obesity and how we can think about policy issues that really encompass our needs and strategies in the context of this collision of pandemics, obesity, and COVID-19. What is important for us to note is that this pandemic has led to more death in the United States than any country in the world, and it's hit us especially hard because it became on the top of another health crisis that disproportionately devastated Black and Brown communities. And of course, that is obesity, the context for our conversation today. And what we do know here in the United States is that the obesity epidemic impacts over 42% of all Americans, and that the numbers are even higher in Black, Hispanic, and Indigenous communities, with obesity rates of nearly 48% and 45%, for example, in Black and Hispanic communities, and that over 70% of Americans have overweight and obesity. So it's important for us to recognize just the sheer volume of those numbers. What we also know is that recent studies clearly indicate that people with obesity and COVID are at higher risk of getting seriously ill and hospitalized, as Dr. Wilding mentioned a bit earlier. And we have more people, like I said, particularly people of color battling obesity here in the United States than anywhere else in the world. And we can't tolerate inaction from our leaders any longer. As you know, Washington, D.C. governs what we do here in terms of a political front, and it's time for Washington to treat obesity like the disease that it is, rather than the personal failing that it is not, and to do its part to treat the most vulnerable Americans with targeted legislation, such as what we've introduced here in the United States, both in the House and the Senate. It's called the Treat and Reduce Obesity Act, or what we call TROA. And for those of you who are unfamiliar with TROA, TROA is a bill that looks at two key tenets. Number one, it looks at the treatment of obesity from the perspective of behavioral coverage For example, dietitians aren't covered with fees unless they already have a diagnosis of diabetes here in the US. If they have obesity, they do have out-of-pocket costs associated with accessing a dietitian, which I think is a little bit backwards. In addition, when we look at the treatment of obesity from the perspective of pharmacotherapy use, weight loss medications, which have been shown to be quite effective for patients, we see only 2% of Americans access that. And so we want to really stand for coverage. It's important for us to note that our long-standing approach to weight loss, one that emphasizes willpower and quick fixes, is clearly broken and doesn't align with what is known about genetic, biologic, and environmental factors that contribute to obesity. And I've spent my medical career not only conducting obesity research, but also working to improve the lives of the countless patients that look like me, patients who often feel hopeless and lost in this broken system. And the data backs this up. In 2019, health insurance plans spent $344 billion on weight issues here in the United States alone, while consumers spent $290 billion on weight loss products. Yet the country still gained 1 to 2 pounds per person. So doctors and scientists like myself are studying metabolic health, and we've known to sustainably treat obesity, which impacts large portions of our communities. But it comes down to finding the optimal strategy, which may include successfully combining prescribed medication, personalized coaching over a year or more to give people the metabolic reset that they need to lose excess body weight and keep it off. But with 175 million Americans with obesity and just over 4,000 obesity doctors here in the United States, and less than 50 of us who have received fellowship training, access to proper care and treatment is nearly impossible. The approach to tackling obesity has proved so successfully that it's one of the few things that Democrats and Republicans here in the United States have agreed on, actually, in the past few years, where we have had some significant disarray. What we do know is that this TROA bill, the Treat and Reduce Obesity Act, was introduced by Congress back in 2013, when the American Medical Association first began to acknowledge obesity as a disease. And while it has over 170 congressional co-sponsors, it has still not passed. We have to do better. Now, when we look at this from the global perspective, there is this campaign to build back better. And what this is taken from, in terms of what I'm going to say, is a wonderful piece that came out, The Time to Act Is Now, on obesity, published and co-authored by Kate Aldrich Turner from the World Cancer Research Fund, Lucy Westerman of the NCD Alliance, and Margaret Naveau of the World Obesity Federation. And if I mispronounced your name, I hope that's acceptable, and I apologize. It's important for us to note that while we talked about the high rates of obesity here in the United States, we do know that it affects greater than 13% of the population, and actually more along the lines of 20% of the population. And it costs about $990 billion per year if we look at it from a national perspective. And when they talk about how we as governments can really act on non-communicable diseases, there are a few strategies that propose that I think are warranted for me to discuss. Number one, to increase government investment in the prevention, management, and treatment of obesity. So prevention, management, and treatment, really a three-pronged approach to ensure that nutrition responses integrate and address malnutrition in all of its forms: undernutrition, overweight, obesity, stunting, wasting, and other nutrition-related non-chronic disease. And to address the root causes of malnutrition, incorporate health in all policy approaches. To focus on implementing double-duty actions to address malnutrition, and to urgently implement comprehensive policies and actions to improve food environments, to improve access to care for the treatment of obesity. And then finally, to ensure policies, partnerships, and dialogues related to obesity that are conducted in the principles of engagement to protect from inappropriate and vested interests, which may undermine one's health. What we do know is obesity is the most prevalent chronic disease of our lifetimes and is only continuing to grow, both in developed countries and developing countries. And so we need to look beyond a simple approach where we're just looking at diet and we're just looking at exercise, and we're looking at the more than 100 causes of obesity where behavior, environment, development all play a role, but things such as the gut microbiome also may play a role. It's important for us to do better, look at the complexity of the disease that it is worth, and make policies to address this both here in the United States and around the world. Thank you so much for your time.
Thank you very much indeed, Fatima. So we move on to the last of our presentations, which is from Karina Hawkes from City University London, who is Director of the Centre of Food Policy at the University of London, Vice Chair of the London Child Obesity Task Force, and a Distinguished Fellow at the Georgia Institute for Global Health. Karina, over to you.
Thank you, John, and delighted to be part of this reflections after a fantastic series of webinars. And thank you very much to the World Obesity Federation for hosting those webinars. What we've seen during COVID-19 is increasing attention being paid to the food system, which is what I'd like to focus my remarks on over the next few minutes. When the lockdowns first came into place, or the quarantines or the curfews, whatever the policy responses were, it was the food system that suddenly became so important in people's minds as having been affected, because suddenly people were faced with the reality that they weren't perhaps able to get the food that they were used to getting. And so the food system immediately became visible in a way that it hasn't been for quite a long time. And as a result of COVID-19, the food system was affected and also responded. It's very difficult to generalize about those impacts. There was a lot of talk about food system fragility, and that has played out in certain circumstances. And the food system has in other ways proved fairly resilient, and that varies over time, place, context, and so on. But what is indisputable is that the food system was raised as an important critical factor in our lives. And this is really important to obesity, because one of the issues that came out so strongly is that the food system is not fit for purpose from an obesity perspective. So the way that our food system is designed is to provide food to people. And that's great. It often works extremely effectively for people who are able to afford the wonders that the food system is able to provide. But what came out quite clearly is that it didn't deliver very well in the context of inequality. So people became more food insecure. But also it wasn't necessarily delivering the healthiest foods. During lockdowns, often people resorted to consuming more snacks and so on. They were more readily available, and there were other issues that have already been mentioned. There was more advertising, all of the issues that meant that people were more exposed to unhealthy foods. And this is an indicator that the food system is not designed to deliver health. That's not how it was designed. But what we saw during COVID-19 was people invested and innovated in actually trying to change that, to say people don't have access to fresh, healthy foods anymore. There is fresh, healthy foods being wasted in the fields and so on. We are going to try and make a plan, introduce some initiatives to try and change that. So, for example, some countries put into place giving out free seeds to families so they could grow their own. In other areas, there are new distribution points for urban gardens and urban agriculture. In others, things like community initiatives like community kitchens and distribution of food packages sprung up. And in still more, there were initiatives like veg boxes designed to bring food, healthy food to people in the distribution networks. So what we saw for the first time in quite a long time was innovation in actually planning and trying to design the food system so it got healthy food into people's hands. And that's not how the food system is being designed. So what the lesson for us is that we need to redesign the food system with a plan so that the purpose of the food system is to deliver nutritious, healthy food to people, not unhealthy food to people. And that takes a plan. It means not just leaving it to the market. It means not just leaving it to people's preferences, if you like. It means planning and purpose. And the fortunate element here is that the UN Food Systems Summit is being held next year. So this is a fantastic opportunity for those of us involved in obesity to actually take this and say, we need to plan for a food system which is not obesogenic. And we need to discuss this at the UN Food Systems Summit. Is an ideal opportunity to be taken forward in the wake of COVID-19. But when you look at that Food Systems Summit, it's very clear that it's focused on all the different elements of the food system. So what we need to do is to say, how can those of us who work in obesity synergize what we want with other aspects of the food system? So it's those double duty actions that were already mentioned with undernutrition. It's finding ways of tackling our consumptogenic environment, which leads also to climate change. It's around saying the food system is also a provider of economies and livelihoods. So we need to find alternative and emerging business models that will provide jobs in the food system by providing healthy food. So there's a tremendous opportunity to learn from what happened to the food system and the innovation in the food system during COVID-19, to take that forward and to start a real conversation towards the UN Food Systems Summit about how the food system can deliver a healthy food environment for everyone, while also delivering reductions of climate change and other environmental concerns and livelihoods for people in the food system in an equitable manner. Thank you.
Great. Thank you very much, Karina. We've now got about 10 to 15 minutes, I think, for some discussion. And there's been some fantastic questions coming in, and we may not have time to address all of them, but some of them seem to focus around some common themes. So I'm going to try and sort of do this in a sensible way that brings in most of the questions, although I may not ask your specific question. I hope we will cover those topic areas because there's probably about 20 questions, or I've got 19 open questions, and we're never going to have time to answer those. So I think one of the points that I think quite a few people have made in slightly different ways, and really I think probably this is initially probably for Karina and maybe Tolu to comment on first. Is this and you've just commented on that, Karina, is this kind of conflict between the commercial systems at the moment, which are trying to drive us towards unhealthier and unhealthier foods, and the health systems which are trying to say we should eat healthier foods, and that creates a huge conflict. And it also means we're advising people maybe as healthcare professionals to eat in a certain way, and yet all the messaging they're getting from everywhere else is the opposite to that. And so that creates a very difficult conflict for people, I think. So I don't know whether either Karina or Tolu want to comment on that first, or if anybody else wants to, you're very welcome to. I think Tasha has an interest too.
I'll just respond to that. I mean, it's a really critical issue, and one of the things that I think is important to see here is incentives across the system that are designed to move it away from those less healthy foods. And we've seen an enormous amount of financing. I mentioned this in a previous World Obesity Federation session as well, that there's an enormous amount of money being spent at the moment in the system, in the food system. And it would be nice, to say the least, to see some of that being used as a stimulus package for healthier food companies and healthier food businesses, including smaller and medium-sized enterprises and those which are more about direct farm to consumer initiatives, for example, because we need to really kickstart a new economy around healthy food. And unless we do that, the pushback from governments will always be, well, we'll lose jobs, our economic growth will go down. And with all of this money being spent, let's spend some of it on kickstarting healthy food.
Yeah, thanks very much. Tolu, I think you wanted to come in next.
Yeah, no, I think it's such an important question and comment. I mean, it summarizes the reason I got into urban health, because as a physician seeing patients, it just kind of felt like I was complicit in giving advice that I knew they couldn't take up, to eat healthier or to be physically active. Of course, healthy eating is part of a broader healthy living behavior. So because Corinne is focused on the food system, I want to just point out the built environment and physical activity as well. Colleagues actually of mine from South Africa recently published something around the notion of physical activity security in a similar manner to food security, healthy food security, as a way of thinking about how environments are designed to promote physical activity and to protect physical activity equitably. Because the reality is, it's in many cities where we see this rising obesity prevalence, it's not actually a rational choice to take active transport or to be physically active for leisure, particularly if there isn't funding required in private gyms, etc. So how do we make that the rational choice? And it's really critical, similar to what Karina said about the incentives. And particularly in the built environment, it views itself as somewhat agnostic. So it's not, I don't think anyone's necessarily trying to build an unhealthy environment from a physical activity perspective, but it's just not consciously designed into it. And I think it just speaks to the importance of this closer working together to say, how do we insert health objectives into the building and design of cities? Because my experience working with human settlements and urban planners is that there actually isn't a pushback, but there's an institutional limitations. And so it's really critical that all of those silos that have been set aside for COVID responses, let's not put them back up, because actually they were stopping people being able to adapt to health objectives.
Okay, Tolu, thanks. I just one sort of further point that I would just make that I think reflects something, questions that have come up, is one way, I suppose, of doing this is to actually make a kind of health impact, health risk assessment pretty much compulsory anytime you're involved in urban planning. And I don't know whether that's happening anywhere in a consistent way. Do you know of anywhere where that's actually happening? Can we keep the answer short?
Yeah, so there are some examples of, so there is, for example, there's a healthy architecture index. So there are examples of these where you look at these criteria of building, both buildings and neighborhoods. There's an example in Essex, for example, of a development where the developers are working with the local authority and the community around active living and designing that as key part of the development. There are examples around developers who are certified around those healthy indices being preferentially favored in terms of tenders around that. But really, fundamentally behind that is leadership. So the political leadership to put those systems in place and to request that, even when they exist, is really critical to all of that.
Thank you. I'm going to move on now and ask Fatima a question which has come up. And this is about obesity across the life course, and it relates specifically to the United States, but I'm sure it would actually apply anywhere in the world. So what strategies do you think we need to put in place if we're going to address this problem, not just in adults, but in preconception through to conception, through to children, through to adults?
Absolutely. I think that you bring up, actually, one of your last words was a key word, preconception. So what we do know is this idea of fetal programming is such that if parents go into a pregnancy, meaning they conceive when they themselves have obesity, that persons that are born, their children, have a 50 to 85% likelihood of having obesity themselves. And that's even when we've optimized our environment. when we've looked at our food systems, when we have access to healthy foods, exercise, etc. And so it's important to note that we really need to be targeting the entire population. 50% of pregnancies here in the United States are unplanned, which means that we can't just target those that are actively trying to conceive. We need to target every single individual and recognize that if they indeed themselves have overweight and obesity, that it will yield the likelihood that their child will struggle. Yesterday, I saw an 11-year-old, and we use, of course, pounds here in the US, so I should probably divide this out, who is already 250 pounds. But if you go a little bit deeper and you look at her parents, her grandparents, and her great-grandparents, it was her great-grandmother who was actually on her telemedicine visit with her, everyone has severe obesity. And so it's this kind of bewilderment from the family that this young girl would have such severe obesity. To me, it was very simple. We have she was dealt a certain card deck. She was dealt a card deck where she was born into a family where both her maternal and paternal sides had severe obesity. So I'm having to address the obesity across the life spectrum. As an obesity medicine physician who takes care of children as young as 2 and adults as old as 89, I can tell you that many times I'm working with multi-generational and using different treatment approaches to impact those individuals within that community with the same messaging. It's not just your fault. We have to be doing better as individuals that treat obesity to ensure that we're giving the best possible care. And if you look at the outcomes for my patients, they are overall quite successful in ways that they have never been successful throughout their lives, if they're older patients or what we'll call more advanced in age, or for my younger patients that we're intervening early enough that it doesn't lead to other obesity associated complications like type 2 diabetes, heart disease, obstructive sleep apnea, just to name a few.
Yeah, thanks very much. I'm just going to ask one question. I'm going to ask Ada a question because we've really only got time for 2 more questions. One is, Ada, there's a lot of questions that kind of relate to, are there special foods? Should we be taking vitamins? All these types of things about prevention of COVID. And I just would like you to, if you can, in a nutshell, say what you think is important there. And then I'm going to finish off with a question to Tasha.
Yeah, well, shortly, I think that the most important is that we encourage healthy nutrition to our patients. And obviously physical activity with if they are able to do in outdoor places. I think that this is the basic for all of them. Healthy nutrition and promote probably to have their own production if they are able to do it. But in regarding to supplements and vitamins, we have to be very careful to teach to our patients, because usually in the media they can see any promotion of different products, and we have to be able to tell them what really are useful. We know, for example, that vitamin D can be useful to in patients that have low levels of vitamin D that may have a more severe COVID-19. So this kind of thing we have to teach to our patients, but maybe encourage to them, don't follow the recommendation that appear in the media. At least in Latin America, the people use so much all these kind of natural products that promote to lose weight, improve immunity, and many other magic effects.
I think I need to be on. Thanks very much, Ada, and thanks for keeping that brief. So I'm just going to, I think it's always important that we allow the young people to have the last word. So Tasha, if I could ask you a question, which is, if there was, one thing that you could do as a young person, how would you encourage your friends and other people of your age to act, to try and make this all happen? Because I think we've heard today that there's a lot of things we can do, but some of it's about getting the political will. So and the young person's voice is very strong in this. So how do you think you can make that happen?
I think for me, it's about encouraging and empowering young people to recognize that their voice is important, and that the ideas and opinions and the unique experiences, and how they've experienced the food environment, what they have to offer is very, very valuable in terms of coming up with an obesity strategy that is child initiated and reflects the experiences of young people. So for me, like I said, it's empowering them and being given the platforms, the forums to actually speak, but also not just to speak and have their words fall on empty ears, but also to make sure that policymakers and adults are ready to take on these opinions and these ideas and actually implement them. A lot of the time, discussion on childhood obesity, it happens amongst adults, but it's about children and young people. I find that really absurd. For me, it's about having, these discussions include young people to make sure that our opinions and our voices are heard, and that is reflected in any strategy. So I guess it's, it's a multifaceted approach, but definitely having youth engagement involved in the whole entire process from beginning to end is really important. And that can only happen by empowering young people with this idea, with this belief that their voice is valuable and that the world is waiting to hear about what they have to offer.
Thank you very much. I think that's really inspiring, and I hope that those of us who are a little bit older will listen to that and take heed. Okay, I've just got 2 slides to finish off because we are out of time. I know there's been lots of questions that haven't been answered. We will try and answer those offline, and obviously the discussion can carry on through the World Obesity, and I'm sure it will continue for a long time to come. So just looking into the future, and I think we've covered a lot of these areas today. There are areas where we can actually work to ensure a healthy recovery from COVID-19, where there's a triple win here. And we've talked today about the healthy diets being important for not just for obesity, but for other conditions. We've talked about the relationship a little bit between undernutrition and obesity, and the fact that many people with obesity are maybe undernourished in some areas of their nutrition. We've talked a little bit about sustainability and the link to climate change, and how we need to think about sustainability of food production, sustainability of transport, moving towards active transport, making our cities healthier. And all of these things actually are pushing in the same direction. And so if we think about that, we have, in terms of prevention, there's a real opportunity here, and we need to seize that with both hands if we're going to make it work. And then the second part, which comes in the next slide, is about health systems and about treatment strategies. And we haven't touched on all of these things today, but in terms of prevention of COVID-19, we need to ensure people have healthy nutrition. And as vaccines become available, we need to ensure that people with obesity, where appropriate, are considered into the high-risk category and get priority for those vaccines. We need to ensure that, just like any other health service, that services to support people living with obesity who are going through treatment are able to continue, and that there is resilience in those health systems that allows that to continue even in the context of a pandemic. And that obviously is going to be really tricky, but it is something that we have to make sure happens. And that means investment in appropriate health systems. And we've heard, that there is a big push, in the UK that's happening. We've heard that's happening in the United States. And I think that's going to be something that's really important going forward. So I'd just like to finish by thanking everybody for attending this webinar. I think we've had a great discussion. As I've said, there is this online dossier. The web links are there. There's the e-learning module on COVID-19 obesity, and the web link is there for that. And just a quick advert for our Scope Global School on childhood obesity on the 8th and 9th of September. So thanks everyone for attending this really fascinating seminar, and thanks to all the panelists for fantastic contributions, and for all those who asked questions as well. Thank you very much. And please don't forget to fill in your feedback form. I've just been reminded.